Okay, good morning, everyone. It's really a pleasure to be here, and I'm happy to share today with you some recent unpublished data we've generated around the performance of selected RDTs for the detection of asymptomatic malaria infection. As a brief way of introduction, since the introduction of malaria RDTs in the late 90s, we've been working with products based on 3 biomarkers only, HRP2, LDH, and aldolase, and we use these products for clinical case management, passive case detection. And as such, we've been setting performance target at 2,200 parasite per microliter, not lower than that. I think it's fair to say also that we have few species-specific products besides falciparum, and that we have, as compared to falciparum product, we see relatively poor PV performance with malaria RDTs. And for the past 20 years or so, there has been very limited innovation in these fields, and mostly because there was no perceived strong need for innovation. We were doing, in principle, just fine with this product for clinical case management. But I think this picture started to evolve slightly since a couple of years already, with new critical needs emerging. The first one being the elimination imperative, so meaning that we need point-of-care tests to support active case detection, going after those low-density asymptomatic infection. Another need is overcoming the Vivax neglect, so clearly we need better products for Vivax. And we also now, we've seen since quite a few years actually, HRP2, HRP3 deletion, so potentially having new biomarkers for falciparum is also something important. And I think with this new picture, the product that we have, they do not really fit quite well with these needs. And so there is now, I think, a clear need for innovation. That's the, well, basically efforts to come with this needed innovation, supported by BMGF, are coming to fruition. And so we, since a bit more than a year now, we have the first of these so-called highly sensitive RDT that is commercially available. So just very briefly, this is HRP2-based RDT. It has 10-fold improved analytical sensitivity. It works just like a normal RDT, so it takes 5 microliter of capillary blood. You have results in 20 minutes, and reported LOD in terms of parasitemia are in the range of 1 to 10 parasite per microliter, although it's a bit, we shouldn't necessarily talk about LOD in terms of parasitemia, and I'll come back to this during my presentation. So what I'll show you today is basically us taking advantage of a relatively large asymptomatic specimen bank that we've been developed to support the development of this test, to look at what is the actual performance of this test that has been specifically developed to do active case detection, look at asymptomatic infection, and actually understand how it compares to other RDTs, especially because the way RDT performance is evaluated is against that threshold of 200 parasite per microliter, and it's not suited to detect improvement in performance below that level. So let me give you a few words about that specimen bank. So it contains 1,120 EDTA anticoagulated venous whole blood specimens, which were collected between 2015-17, which are stored as 200 microliter aliquot. We've been setting up specimen collection in 7 different countries. This includes Peru, Senegal, Côte d'Ivoire, Zanzibar, Cambodia, Vietnam, and the Philippines. And the way we went about this specimen collection is the following. So we've been setting up cross-sectional surveys in all these countries, screening typically 1,200 people or more. And I'm specifically mentioning that we excluded people with recent clinical malaria episode, because we were trying to actively filter out for HRP2 persistence. So obviously, because we were going after asymptomatic, obviously one exclusion criteria was actual fever or history of fever in the past 7 days, but we also excluded people who have taken an antimalarial in the past 4 weeks. And we've been screening people on site with LAMP or mobile PCR when it was available. So on one hand, this gave us an estimate of what is the asymptomatic prevalence in those sites in adult populations. And because of this technique, we managed to have results within less than 24 hours, so we could get back to a subset of those people and collect venous blood from typically 100 negative individual and 25 PF positive individual, and also 25 Vivax when it was in a Vivax endemic country. So we would typically collect 15 milliliter of blood that we would rapidly aliquot and freeze on site. And we were using, and we got in average about 70 aliquots from specimen. And we were using some of them to do quite extensive characterization. So there was light microscopy done on site, but we've been doing also a number of PCR with those aliquot, regular nested PCR, a high volume PCR, reverse transcription qPCR on a subset of the samples. We've been looking at the antigen concentration using a classical ELISA, but also highly sensitive Quansis Qplex ELISA together with SPAS. We looked also for the PF samples at the HRP2, HRP3 deletion and have done the HRP2 genotyping. So this is what we ended up with. So in total, we've been screening a bit more than 11,000 people, and you see that the P. falciparum asymptomatic prevalence in those different countries range from 0.6, very low in Zanzibar, where we've been screening close to 3,000 people, to as high as almost 14% in Côte d'Ivoire. And we've collected around 150 specimens in all those countries for a total of 1,120 specimens, representing roughly about 70,000 aliquots. This is what we got. So about 160 PF samples, close to 80 Vivax, and a few ovale malariae that we collected along the way. Couple of mixed species infection, 3 undetermined, and close to 800 negative specimens. So looking at the parasitemia distribution of these samples, you see that it varies based on the species. We have very low parasitemia for the ovale sample, but otherwise for falciparum, Vivax, malaria, it's around 10 parasites per microliter, a geometric mean. And it ranges for falciparum, it ranges from 0.1 to 10,000 parasites per microliter, which is actually a 0.2% infection, which is in fact relatively quite high. Looking more specifically at the PF samples, we looked for HRP2 deletion, so we didn't find any in Cambodia, Côte d'Ivoire. Not surprisingly, we had a lot in Peru, almost 100%. We found 2 in the Philippines, and I think it's the first time that HRP2 deletion is reported from that country. None in Senegal, Vietnam, and Zanzibar. And looking at the parasitemia distribution of those PF samples by country, there is no obvious strong country specificity here. It is around 10, 50 parasite per microliter geometric mean. Comparing parasitemia with HRP2 concentration, we see, as expected, some level of correlation, but a poor correlation. And illustrating that is the fact that at saturation, so at 16 nanogram per milliliter of HRP2, you see parasitemia ranging from 2 to 2,000 parasites per microliter. If you look at samples with a 2 parasite per microliter parasitemia, you see HRP2 concentration actually going all the way from the lower limit of quantification of the assay at 1 picogram per milliliter to the upper limit of quantification to the assay at 16 nanogram per milliliter. So coming back to my point that relating or stating a limit of detection in terms of parasite per microliter for an assay that is measuring antigen is to some extent complex and not straightforward. So again, we've been taking advantage of that specimen bank to look at the ultra-sensitive RDT and to look at a number of other RDT, again, because the classical RDT evaluation program would not be able to discriminate performance differences below 200 parasites per microliter. So we've been selecting the 8 best HRP2-based performing RDT from the round 7 results of the testing of the RDT testing program, and evaluated them against this specimen bank. So these are the products selected. all of them have an HRP2 test line, which is the test line of interest here. Some of them also have a second test line based on pan-PLDH. And as you can see that all of them have very high panel detection score at 2000 parasite per microliter, 99 or 100, and also very high panel detection score at 200 parasite per microliter. The second test on that line, so the first test is the ultra-sensitive RDT, which we've been talking about. The second test, it was actually included as a standard comparator for the ultra-sensitive because it's coming from the same manufacturer. The samples we picked from the specimen bank to look at the performance of this test are the following. So basically we've been taking all the monospecies samples that we had, plus a random selection of 200 negatives to match the same geographical origin of those samples. And that evaluation was done at the Pasteur Institute in Cambodia with the group of Didier Ménard. Each RDT was tested in duplicate, and each test was read by 2 readers, and we've been averaging the results of those for evaluation. You see the geometric mean of the different samples we used. You see the average HRP2 distribution, so it's at 6 nanogram per milliliter for the PF samples. We had a few PF HRP2 deleted included there as well. Obviously, there is very low HRP2 level there, and you see that also in the negative, you have a very low HRP2 level. So first, looking at the invalid test. So out of the 906 reactions that we've done with each of the RDT, we've seen very, very few invalid results. Just a handful, and mostly because of absence of control line or red background, but no big issue at all here. And this is, the core of the results. This is showing the sensitivity and specificity of these products when evaluating the 148 PF HRP2 positive samples and the 200 negative ones. So what you see is that actually sensitivity ranges from 36 to 66%, and sensitivity and specificity is universally high at 99 or 100%. So it's quite obvious to see that the ultra-sensitive RDT is the one with the best sensitivity, but there is also a range of sensitivity from these other products that we've evaluated. Looking at this in a bit more detail, we see something that makes perfect sense. So it's those samples with the highest HRP2 content that are seen by all RDTs. You see that it's only the few samples with the highest HRP2 concentration that report that are positive for all the 9 products. As HRP2 concentration decreases, you have less and less RDT positives. If we look at each product individually, it's quite clear to see that what is driving the increase in the clinical sensitivity of the ultrasensitive RDT is the fact that it detects those additional infections at lower HRP2 concentration that are missed by most of the other tests. Based on this data, you can do a logistic regression and estimate an LOD, which is here, set at the HRP2 quantity that would return a positive result in 95% of the cases. So 95% probability of having a positive test at this HRP2 concentration. And again, you see that the ultrasensitive has the lowest LOD. And you see that there are quite some differences between products, but what is also clear to see is that there are products which have an LOD that is not so far off from this one. We also briefly looked at the LDH test line of those 3 products because out of curiosity, really. Here I want to mention that those products were not selected as being the best LDH performing product, so it's not necessarily representative of what you could achieve today if you take the best LDH product, but this is what we've seen with those products. So I'm showing again the performance of the HRP2 test line for the PF infection, and if you look at the pan-LDH test line for those same PF infection, this is what you get. So obviously lower detection, lower sensitivity. If you look at the PV sample, you see that the detection is really low, the sensitivity is really low, not more than 20%. And none of those tests, none of those pan-PLDH test line could detect any of the P. malariae and P. ovale samples, but these are extremely low parasitemia samples, not really surprising. So in conclusion, we've seen that screening asymptomatic individual in all those different countries by PCR or LAMP allowed to identify asymptomatic infection at a prevalence ranging between 0.6 and 14%. Using that specimen bank that actually represents quite a wide geographical diversity, we see that product with quite identical panel detection score can show very variable results in those asymptomatic samples with sensitivity ranging from 36 to 66%. In fact, for all this RDT, including the ultrasensitivity, it's only a fraction of all those infections that are being detected. And the ultrasensitive RDT is, in fact, the product which shows the best performance with a sensitivity that is between 30 to 80% better than the other tests evaluated here against this specific sample set. So what do we take from this? So it's just a simple scheme to show you that while we have those infections that have been seen by LAMP or PCR, we see between 30 and 40% of those with the so-called conventional RDT. We see 66% of those with the ultrasensitive RDT. So I guess the first message is that it's quite clear, and we all know that doing active case detection, screen and treat using conventional RDT does not allow you to get sustainable reduction in transmission. This is not a viable approach. It's slightly beside the point of beside the scope of this presentation, but I think that there is a potential untapped. There is an untapped potential of the LAMP technology here. What we've seen is that in many cases, the negative samples that we collected based on the LAMP results, they were found to be actually negative even when looking at with ultra-sensitive PCR. And of course, it's something you would expect if you collect only 100 samples and have an asymptomatic prevalence of less than 1%, but we've seen the same in places with 5–10% asymptomatic prevalence. So it feels to us that we see most of it with the LAMP in that context. And then, of course, the most important question is what do we do with the infection we can see with that ultra-sensitive RDT? And the typical question is, do we care about those infections? Do we actually need to detect them or not? And what people typically ask is whether, those people have gametocyte. Do they have enough gametocyte to transmit? And so the typical answer is that more research is needed, that we need to understand these things and we need to model this. But maybe this is, in fact, a simple approach. What we would really need to understand is what is the trajectory of those infections. How many of these can, at some stage or another, have the capacity to transmit? How many of these will self-resolve? And so, again, you could do more research to completely model this. But I think when we consider this question, there is also maybe another simple fact that we should keep in mind is the fact that having parasite in you that feeds off your blood is very unlikely to be a good thing for you. So I think that if we could, I think we should remove all those infections, whether they transmit or not, whether they're symptomatic or asymptomatic. Of course, I understand that malaria endemic countries are mostly resource-limited settings, and that you need to prioritize your intervention, you need to prioritize your tools. But I think we should also keep in mind very down-to-earth thing that is parasites are bad for you. The last point is that it seems that there is some sort of continuum between the performance of those different tests. So maybe that dichotomy between ultra-sensitive and conventional RDT is to some extent artificial. Do we really need to set this threshold and this difference? I'm not sure this is really relevant. So final point is there are additional highly sensitive point-of-care diagnostic tests are being developed. I think we'll hear about that in the next presentation, and this is a good thing. I don't think it's the lack of tools that should dictate our anti-malarial strategies. And I think better, more sensitive diagnostic tests will actually mean better and new ways to tackle malaria, not necessarily divergence of resources. And I also think it's clear we need better biomarker to circumvent the limitation of HRP2, so something that shows no persistence unless you're interested to see past recent infection and no deletion. And the final word is about that specimen bank I mentioned. So I think this is a really highly valuable resource. I think it's a unique resource. I think it is a great tool to actually do benchmarking, to do evaluation of diagnostic tests. And the reason we maintain this specimen bank is actually to help in the development of malaria tests that can actually address this type of asymptomatic infection. So we now open this specimen bank to request, and please go to our website to get more information about this if you're a test developer and if you have something that has the capacity to address asymptomatic infection. And this is the acknowledgement. This is really a large collaborative effort. It's really a lot of people we had the chance to work with doing the specimen collection, doing the characterization, and this RDT evaluation. And of course, we're thankful to the sponsor who enabled this work. Thank you very much.